Welcome, curious learners, to the Deep Dive, where we slice through complex topics to give you those sparkling nuggets of knowledge that truly make you well-informed. Today, we're plunging into the intricate world of vascular disease and its surgical management.
It's a field that demands incredible precision and a really deep understanding of the body's most vital systems. What's fascinating here, I think, is how interconnected everything truly is, from the tiniest plaque forming in an artery to the major vessels supplying the brain and limbs.
Absolutely. Our mission today is to give you a shortcut, a distillation of the critical insights you'd need to understand this topic, almost like the elite professionals in the field. We've pored over comprehensive medical texts, and we're going to unpack the details of peripheral vascular disease, various types of aneurysms, and complex carotid artery procedures. We'll cover everything from how these conditions start to the cutting-edge treatments and the critical decisions made both in the operating room and beyond.
Exactly. We'll explore the why behind the what, connecting the dots to give you those aha moments about how these conditions manifest and how they're managed. Think of it as gaining the critical thinking skills to truly grasp the nuances that define professional understanding, without needing a medical degree. 1. Peripheral vascular disease, the foundation of vascular compromise.
All right, let's unpack this. When we talk about peripheral vascular disease, what exactly are we referring to? And what's the main culprit we need to understand?
Well, at its heart, peripheral vascular disease often stems from a condition called atherosclerosis. Think of atherosclerosis as a systemic, progressive, sort of wear and tear process in your arteries. It's not just a simple buildup, it's the formation of these fatty, fibrous plaques primarily within the arterial walls. These plaques gradually obstruct the vessel, like gunk accumulating in a pipe, which reduces blood flow to the tissues further down the line.
So it's more than just a blockage then. How does this gunk develop and what are its immediate dangers?
Exactly. This is an anesthetic problem. The progression of atherosclerosis can manifest in a few critical ways. First, it causes stenosis, which is a narrowing of the vessel. Imagine that pipe getting squeezed smaller and smaller. This can progress to a complete occlusion, a full blockage. Now, when blood flow slows down in a narrowed vessel, it increases the risk of thrombosis, where blood clots form directly in that area. If a large clot forms, it can cause acute organ ischemia, a sudden, severe lack of blood supply to a vital organ.
Okay, so thrombosis is one danger.
Right. Another danger is embolism. Sometimes small fragments of the plaque itself, or tiny clots that form on the plaque, break off. These are called atheromatous debris, or microthrombi. They can travel through the bloodstream, lodging in smaller vessels elsewhere in the body and blocking blood flow there.
Wow.
Lastly, and crucially, the formation of these plaques can actually weaken the arterial wall, setting the stage for a dangerous bulging or ballooning known as an aneurysm.
That dynamic nature sounds concerning. And you mentioned this is considered an inflammatory condition, which might surprise some. Why is inflammation central to atherosclerosis?
That's a crucial insight for understanding this disease. It's not just about high cholesterol, it's an active inflammatory process. It starts when cholesterol plaques begin to accumulate in the artery walls. Your body's immune system, recognizing these as a problem, sends in specialized white blood cells, like macrophages and monocytes. These cells, in an attempt to clean up, actually release powerful signaling molecules called pro-inflammatory cytokines.
Okay.
These cytokines, in essence, act like fuel, intensifying the inflammatory response and leading to the continued growth of the plaque. This plaque often has a thin outer layer, a lipid cap. If this cap ruptures, it exposes the highly reactive contents of the plaque to the bloodstream, which can immediately trigger a large blood clot to form right there, or release fragments as emboli, sending them downstream. So it's not a passive gumming up of the arteries. It's a constant active battle that can spiral out of control.
So, if inflammation is fueling it, what are the big red flags, the lifestyle factors or conditions that put someone at high risk for this widespread problem?
The risk factors are incredibly important for both prevention and clinical assessment. We see common culprits like advanced age, smoking, hypertension, diabetes mellitus, insulin resistance, and obesity. Genetic predisposition and a family history also play a significant role. Other factors include physical inactivity, and interestingly, male gender seems to carry a higher risk. More subtle markers can include elevated C-reactive protein, that's a general marker of inflammation, and certain lipid abnormalities like hyperlipidemia or hypertriglyceridemia. Among all these, smoking, chronic inflammation, and diabetes are truly major players in how atherosclerosis develops throughout your entire arterial system. They contribute to what we call endothelial dysfunction,
Hmm.
essentially damaging the inner lining of your blood vessels, making them less adaptable and more vulnerable. And here's the so what. If we see atherosclerosis in one part of your body, like your legs, we must assume it's also impacting other critical areas, such as your heart, brain, and kidneys. It's truly a systemic disease.
That makes it clear why it's such a widespread concern. What are the classic signs a patient might actually feel when they have peripheral occlusive disease?
The symptoms can be quite specific and often debilitating. The most common is claudication.
Claudication, okay.
Yeah, which is a cramping pain or aching in your leg muscles that reliably comes on with walking or exercise and goes away with rest. It's essentially your muscles crying out for oxygen they're not getting. As the disease progresses, you might see skin ulcerations that don't heal, gangrene, which is tissue death, particularly in the toes or feet, and in men, impotence if the blood supply to those areas is compromised.
Right, because the blood flow just isn't getting there.
Exactly. The body does try to compensate by developing collateral blood flow, where existing smaller vessels enlarge or new ones form to bypass the blockages. Angiogenesis, essentially. But this natural bypass isn't always sufficient. It's a stark reality that patients with widespread vascular disease have a 2 to 6-fold higher mortality rate than the general population.
Wow.
This is partly due to the blood becoming more prone to clotting, a state called hypercoagulability, which interacts with the inflammation to worsen the atherosclerotic process. Platelet-leukocyte interaction is a key factor here.
Given that wide range of symptoms and progression, what's the general strategy for treating peripheral occlusive disease? It sounds like there's no single magic bullet.
No, it's definitely a spectrum of interventions. Treatment can range from managing risk factors and symptoms with medications, what we call pharmacologic therapy, to more extensive surgical interventions for advanced disease. When surgery is needed, we have several approaches. Transluminal angioplasty is like using a balloon to widen the artery from the inside. Endarterectomy is a surgical removal of the plaque itself. Thrombectomy is specifically removing a blood clot. Endovascular stenting involves placing a mesh tube to keep the artery open. And then there are various forms of arterial bypass, which are essentially creating a detour around the blocked artery.
Bypass, right, like a road detour.
Exactly. Common bypass surgeries include connecting the aorta to the femoral arteries, aorta femoral, or bypassing from the armpit artery to the leg artery, axillofemoral, or even from one femoral artery to the other, femoral. Femoral-popliteal procedures bypass from the thigh to behind the knee. These are broadly categorized as inflow or outflow bypasses, depending on whether they're restoring blood flow to or from a major branch, with the groin acting as a dividing line.
Makes sense.
During any bypass, the surgeon must temporarily clamp the diseased artery, which, stops blood flow and oxygen to the tissues beyond the clamp. Even with the body's natural collateral circulation providing some alternative flow, if the disease is severe and clamp times are long, oxygen supply can fall dramatically short, potentially leading to critical issues in the heart, brain, kidneys, or severe limb ischemia. 2. Abdominal aortic aneurysms, AAA, a deep dive into a silent threat.
Here's where things get really interesting. Abdominal aortic aneurysms, or AAAs. These sound incredibly dangerous. How common are they, and why do they seem to be discussed more now?
AAAs are certainly a significant concern. They're estimated to occur in maybe 3% to 10% of people over 50 in the Western world. We're hearing more about them not because there's a dramatic increase in how often they occur necessarily, but because we're much better at finding them.
Detection.
Right. Increased screening of asymptomatic aneurysms using non-invasive methods like CT scans, MRI, and ultrasound has significantly improved detection. Their occurrence does correlate with our aging population, and men are affected 2 to 6 times more frequently than women, with white men at a higher risk than black men. For men, AAAs typically start appearing around age 50 and peak around 80.
What puts someone at risk for developing an AAA? Are they the same risk factors we discussed for general atherosclerosis, or are there particular ones that stand out?
Many overlap, yeah, because AAAs are often a manifestation of widespread atherosclerosis, but some are particularly strong independent factors. Smoking is, without a doubt, the most highly correlated risk factor. It increases AAA incidence 5-fold in smokers.
5 times, wow.
Yeah, it's huge. Other significant independent factors include older age, male gender, and a family history of aneurysms. Coexisting conditions like coronary artery disease, high cholesterol, and chronic obstructive pulmonary disease, COPD, are also important. Interestingly, even height plays a role, with taller individuals having a slightly increased risk. And again, those ongoing inflammatory processes driven by elevated cytokine levels are deeply implicated in weakening and dilating the aortic wall that leads to AAA formation.
The word aneurysm itself implies something scary. What are the mortality rates associated with AAAs, especially if one ruptures?
The gravity of a AAA cannot be overstated, particularly when considering rupture. Elective AAA repair is actually one of the most common vascular surgeries, with around 40,000 operations performed annually in the U.S. The good news is that mortality rates for elective repairs have dramatically decreased. They were maybe 18–30% back in the 1970s, but now the estimate is around 1–11%, typically hovering around 5%.
It's a big improvement.
Huge. And it's a testament to better detection, earlier surgical intervention, extensive preoperative preparation, refined surgical and anesthetic techniques, and superior monitoring.
So when is surgery actually recommended? You mentioned the size matters.
It does. For AAAs less than 4 centimeters, the rupture risk is very low. But once an aneurysm reaches 5 centimeters or greater, the risk of rupture dramatically increases. Surgical intervention is generally recommended for AAAs 5.5 centimeters or larger. Of course, any ruptured AAA is an immediate surgical emergency. Other triggers include a 4-centimeter AAA that grows significantly, more than half a centimeter in under 6 months, or any symptomatic AAA, regardless of size. For eligible patients with a reasonable life expectancy, elective repair of a 5-centimeter or larger aneurysm is a proactive, life-saving measure.
So early detection is truly the key to survival.
Absolutely. Elective surgical mortality is less than 5%. In stark contrast, an untreated AAA has a staggering 5-year mortality rate of 81%, rising to 100% at 10 years.
Good grief.
Yeah. If a AAA ruptures, the mortality rate is tragically high, estimated at 35% to 94%, with an overall combined pre-hospital and operative mortality of maybe 80% to 90%. Preventing rupture through elective repair is, therefore, critically important.
How are these silent threats usually found? Are they always obvious?
Many AAAs are silent. They don't cause symptoms until they're very large or rupture. Sometimes they're found incidentally as a pulsatile abdominal mass during a routine physical exam, but smaller ones are easily missed. Less than 30% are identified this way. To improve detection, doctors use a scoring system that includes other risk factors like carotid or peripheral artery disease, obesity, hypertension, smoking, diabetes, and age, which can increase detection to almost 90%.
Okay, so risk factors help guide screening.
Right. For imaging, ultrasound is a minimally invasive first step to detect in AAA. But for precise details like exact size, shape, and involvement of other vessels, CT angiography, or CTA, is the gold standard. CTA gives surgeons the high-resolution, rapid images they need for precise surgical planning, whether it's for open surgery or the endovascular approach we'll discuss later. Open surgical repair, OSR, the traditional approach.
Now that we know what we're dealing with, who actually qualifies for open surgical repair, given how invasive it sounds, and what does that mean for their overall health?
Well, despite its invasive nature, open surgical repair, OSR, remains a vital option. The 30-day perioperative mortality rate is actually pretty low now, maybe 3% to 4.5%, thanks to all those advances in surgical and anesthetic techniques. Most patients, even the elderly, are candidates. Crucially, it's not chronological age, but physiological age, meaning the overall health and reserve of your body's systems. That truly indicates surgical risk.
Right, how well their body is actually functioning.
Exactly. However, some conditions do make elective repair too risky. Intractable chest pain, angina, a very recent heart attack, MI, severe pulmonary dysfunction, or chronic renal insufficiency. Interestingly, patients with stable heart disease and significant coronary artery narrowing who need non-emergency AAA repair generally don't benefit from preventative heart bypass surgery if they're already on optimal beta blocker therapy.
Okay, that's important.
Yeah. We also identify high-risk patients based on a range of factors, being over 70, female gender, or having a history of various heart issues, endocrine problems like diabetes, neurologic issues like stroke, renal problems, or pulmonary conditions like COPD or emphysema.
I remember hearing about the law of Laplace somewhere. What does that have to do with aneurysms and their risk of rupture?
Laplace. It's absolutely fundamental to understanding why aneurysms are so dangerous. The law of Laplace states a simple but critical principle. T equals P times R. Wall tension equals transmural pressure times the vessel radius.
Okay. T equals PR.
Right. What this means is, as an aneurysm, that bulging part of the artery gets larger, its radius R increases. So the tension T on its wall increases dramatically, even if the pressure P stays the same. So the larger the aneurysm, the higher the likelihood of it spontaneously rupturing. It's a direct physical relationship.
That makes intuitive sense.
It does. And even aneurysms under 5 centimeters, while not always requiring immediate surgery, are not benign and need careful monitoring. The rupture risk skyrockets with size. Less than 4 centimeters, it's near zero. 4 or 5 centimeters, maybe 0.55%, 5, 6 centimeters, 3, 15%, 6, 7 centimeters, 10, 20%, 7, 8 centimeters, 20, 40%, and over 8 centimeters can be as high as 30, 50% per year.
Wow, exponential almost.
Pretty much. Interestingly, rupture can sometimes happen more often at spots with low wall shear stress, where blood flow recirculates, leading to thrombus deposition and wall degeneration. Most AAAs form in the infrarenal aorta, below the kidney arteries, likely due to increased wall stress near the aortic bifurcation. But about 5–15% involve the suprarenal aorta, and roughly 40% involve the iliac arteries branching off.
Beyond just assessing the aneurysm itself, what else is critical to get a patient ready for this major surgery?
Preoperative preparation is paramount for success. The most common reason for poor outcomes in these surgeries is a perioperative heart attack. So the main goals are to optimize the heart's oxygen supply and demand and manage existing cardiac risk factors. Beta blockers and statins are key medications here. Beta blockers, ideally started days to weeks before surgery, can significantly reduce cardiac complications by slowing the heart and optimizing its oxygen use.
Right, managing the workload.
Exactly. Statins are also highly recommended, started ideally a month before surgery, because they help reduce inflammation, stabilize plaques, and improve outcomes by protecting the heart and brain. We also meticulously evaluate lung, kidney, and neurological function. The more coexisting health problems a patient has, the higher the overall surgical risk. From a practical standpoint, getting the patient's fluid levels right before surgery is incredibly important to support heart function. We secure robust venous access, large IVs, maybe a central line because massive bleeding is a real threat. We also ensure blood and blood products are readily available and confirm provisions for rapid transfusion and intraoperative blood salvage, which is recycling the patient's own blood during surgery.
Once surgery begins, what are the vital signs and body functions the team is constantly watching, and why?
Monitoring is highly tailored to the patient and surgery type, but detecting heart ischemia, lack of oxygen to the heart muscle, is always a top priority. Standard tools include an EKG lead 2 for rhythm, V5 for ischemia pulse oximetry, capnography for CO2, an esophageal stethoscope for heart breath sounds and temperature, and a urinary catheter for real-time kidney function via urine output. Neuromuscular function is also monitored.
But you mentioned invasive monitoring is key.
Yes. For these complex cases, invasive monitoring is truly vital. An arterial line gives us real-time, beat-by-beat blood pressure readings. This is essential for immediately spotting and reacting to the dramatic changes that occur, especially when the aorta is clamped. It also provides easy access for blood tests like blood gases.
Okay, the ART line is critical. What about things like PA catheters?
Right. The role of pulmonary artery catheters or PA takings is controversial. Many studies show they don't actually improve outcomes like mortality or hospital stay, and they can even increase risks like pulmonary embolism or infarction. They haven't really decreased intraoperative problems and are linked to longer ventilation times and ICU stays. There might be specific indications, maybe in complex cardiac surgery, but not routinely for AAA.
So what's used instead?
Transesophageal echocardiography, or TE, has become a highly sensitive and preferred method. It's like an ultrasound probe placed in the esophagus, giving us a direct view of the heart's function and wall motion in real time. TE is a primary tool for guiding fluid management, detecting issues like low blood volume, hypovolemia, low ejection fraction, right heart failure, or even blood clots in the lungs, pulmonary embolus. Wall motion abnormalities on TE actually show up sooner than EKG changes when coronary flow is reduced.
That's a powerful tool.
It is. Because most of these patients have widespread atherosclerosis, we have to assume some degree of systemic cardiovascular disease. Their blood pressure sweet spot for organ perfusion might be higher than normal, maybe between 60 and 140 millimilli Hg MAP. So even short periods of hypotension can be very risky for cardiac or neurologic ischemia.
This sounds like one of the most critical moments in the surgery when the aorta is actually clamped. What happens to the body then?
Aortic cross-clamping is arguably the most challenging moment for the anesthesia team, due to the dramatic and often unpredictable hemodynamic variability it causes. This is especially complex in elderly patients with existing health issues. The effects depend heavily on where the clamp is placed. Infrarenal, below the kidneys, is most common, but juxtarenal or suprarenal, near or above the kidneys, is more impactful. It also depends on the patient's cardiac reserve and their fluid status.
So what are the main changes?
Well, blood pressure above the clamp rises sharply, while blood flow below it essentially stops. This sudden increase in resistance, or afterload, means the left ventricle has to pump much harder, significantly increasing its oxygen demand. Patients with already weakened hearts are at high risk of congestive heart failure during this period. Your mean arterial pressure, MAP, and systemic vascular resistance, SVR, increase. Cardiac output and pulmonary artery occlusion pressure, POP, might decrease or stay the same initially.
How does the body react?
There's a significant stress response. Plasma levels of catecholamines, aldosterone, cortisol, prostaglandins, and other stress hormones increase. Patients with good heart function can often compensate hemodynamically, but those with ischemic heart disease or ventricular dysfunction cannot. They clinically show increases in PAOP, signaling distress, and require aggressive pharmacologic intervention.
And metabolically, below the clamp.
Right. The lack of distal blood flow creates a hypoxic and ischemic environment down there. Tissues release metabolites like cytokines, prostaglandins, nitric oxide, and arachidonic acid. Anaerobic metabolism leads to serum lactate accumulation. Some of these metabolites, like arachidonic acid derivatives, might contribute to cardiac instability and myocardial depression. Thromboxane A2 synthesis also accelerates, possibly decreasing heart contractility.
And you mentioned mesenteric traction syndrome earlier.
Yes, we can't forget that. It's a unique response specifically to exposing the aorta when the bowel is retracted. It causes sudden drops in blood pressure and SVR, tachycardia, increased cardiac output, and even facial flushing. It seems linked to prostacyclin metabolites. Plus, the general neuroendocrine response to surgical stress mediated by cytokines, catecholamines, cortisol triggers a systemic inflammatory response. Increased temperature, white blood cell count, heart rate, breathing rate, and fluid shifts. Exaggerated responses are linked to longer surgery and clamp times and more transfusions.
So what about vital organs like the kidneys and spinal cord? They seem especially vulnerable during this clamping.
Indeed. Hypoperfusion distal to the clamp is a major concern. Kidneys are very susceptible. Acute kidney injury, or AKI, is common after aortic surgery, and it's associated with high cardiovascular-specific mortality, comparable to having chronic kidney disease. Suprarenal and juxtarenal clamping, above or at the kidney arteries, can reduce renal blood flow by as much as 80%. While even infrarenal clamping reduces it by about 40%.
Yeah.
So higher clamps mean a higher risk of AKI. Up to 18% of patients undergoing aortic aneurysm repair might develop AKI.
What predicts that risk?
Preoperative renal function evaluation is the best predictor. Pre-existing impairment is the main factor. Suprarenal clamp times over 30 minutes definitely increase the risk. Even after blood flow is restored, ischemic reperfusion injury, IRI, can damage renal tubular epithelium, decreasing kidney function, GFR, potentially leading to acute renal failure, which can be fatal in 50–90% of cases.
Are there ways to protect the kidneys?
It's crucial to note that interventions like renal dose dopamine, mannitol, sodium bicarbonate, and loop diuretics have not been scientifically proven to preserve or improve renal function, despite being used historically. However, using balanced crystalloid solutions seems to decrease AKI incidence, and minimizing nephrotoxic medications preoperatively is prudent. Intraoperative renal perfusion with cold solution might have protective effects. Atrial natriuretic peptide, AMP, might be useful, but the most important factors remain aggressive hemodynamic stabilization and minimizing aortic clamp times.
And the spinal cord. Paraplegia seems like a devastating risk.
It is. Paraplegia can occur with an incidence of maybe 113% in thoracic or thoracoabdominal repair, less common but still possible in high AAAs. The spinal cord's blood supply is complex. 2 posterior arteries supply sensory tracts. 1 anterior artery supplies motor tracts, about 80% of flow. Transverse flow comes via the greater radicular artery, also known as the artery of Adam-Kivich. Yeah, its location is variable, usually between T8 and L2, which helps explain why paraplegia can be unpredictable. Interrupting this artery without adequate collateral flow is a major factor. Neurologic complications definitely increase with higher clamp position.
So how do you monitor for this during surgery?
We can use somatosensory evoked potential, SSAP monitoring, which detects dorsal sensory cord function, but it doesn't monitor the motor tracts. Motor evoked potential, MEP monitoring, checks the anterior motor cord, but it's limited if we're using neuromuscular blocking drugs. Alternative methods are still being investigated. Protection strategies include distal aortic perfusion, actively pumping blood below the clamp, cerebrospinal fluid, CSF drainage to lower spinal pressure, and inducing mild hypothermia. Maintaining a good blood pressure, systolic over 120 mmHg postoperatively, also decreases paraplegia risk, especially after thoracic reconstruction.
And the colon, is that also at risk?
Yes. Ischemic colon injury is a well-documented complication. It usually results from manipulation of the inferior mesenteric artery, which often has to be sacrificed during AAA repair, making colon blood flow dependent on collateral vessels. Increased intra-abdominal pressure might also play a role. Mucosal ischemia occurs in about 10% of AAA repair patients, but actual infarction needing surgery is less common, maybe less than 1%.
So the clamp goes on and then it comes off. Is that the end of the challenge?
Far from it. When the aortic cross-clamp is released, it triggers a dramatic cascade called declamping shock syndrome. Remember all those metabolites like serum lactate that built up below the clamp from anaerobic metabolism?
Right, from the lack of oxygen.
Exactly. When the clamp comes off, they suddenly flood the general circulation and induce widespread vasodilation. So SVR decreases sharply. Blood also gets sequestered into previously dilated veins in the lower body, decreasing venous return to the heart. Plus, you have reactive hyperemia, that transient vasodilation due to tissue hypoxia, maybe adenine release, and some unknown vasodepressor substances which can depress the myocardium and cause peripheral vasodilation. This combination leads to decreased preload and afterload. Venous endothelin, ET1, might also play a role in these changes.
How is this managed?
The magnitude of this response can be manipulated. Restoration of circulating blood volume is paramount before clamp release to provide circulatory stability. The site and duration of clamping, plus a gradual release by the surgeon, influence the instability. Effective communication between the anesthetist and surgeon is absolutely vital. Vasopressors and/or inotropic agents are administered proactively to minimize the expected hypotension.
Are there different ways a surgeon can access the aorta during an open repair?
Yes, there are two main approaches. The standard is the transperineal incision, a large cut down the middle of the abdomen from the xiphoid process down towards the pubis. Its advantages are good exposure of the infrarenal aorta and iliac vessels, the ability to inspect other intra-abdominal organs, and relatively rapid closure. The disadvantages include increased fluid losses, prolonged ELIS, that temporary bowel paralysis, significant postoperative incisional pain, and more pulmonary complications.
Okay, what's the alternative?
The retroperitoneal approach is the alternative. This involves accessing the aorta from the side, behind the abdominal lining. Advantages include excellent exposure, especially for juxtarenal and suprarenal aneurysms and in obese patients. It also means decreased fluid losses, less incisional pain, and fewer postoperative pulmonary and intestinal complications. And importantly, it does not elicit mesenteric traction syndrome.
Sounds better in some ways. Any downsides?
The main ones are that surgeons may be less familiar with it. Exposure of the right distal renal artery can be poor, and you can't inspect the abdominal contents. Once the aorta is exposed and clamped, the aneurysm is incised longitudinally. The synthetic graft, like Dacron or PTFE, is sewn proximally and distally, and then the native aortic adventitia, the outer layer, is resewn over the graft to help incorporate it.
Sounds like a lot of blood can be lost in these surgeries. How is that managed?
You're right. Extreme loss of extracellular fluid and blood is expected. The surgical approach, duration, and the surgeon's experience all affect the total blood loss. Most blood loss actually comes from backbleeding from the lumbar and inferior mesenteric arteries after the aneurysm is opened. And the heparin anticoagulation contributes too. Autologous blood via cell saver system is standard practice now. This collects blood suction from the field, washes the red cells, and reinfuses them back to the patient. Options also include preoperative autologous donation or intraoperative hemodilution. This really minimizes the need for homologous donor blood products and their associated risks.
Does using cell salvage make a big difference?
Definitely. While anemia decreases oxygen transport and increases missed stroke risk in vascular patients, one study showed a 75% reduction in banked blood transfusions when intraoperative cell salvage was used. In another study, 80% of patients received only their own blood. Increased banked red blood cell units are an independent risk factor for poor outcomes, but interestingly, evidence suggests no difference in 30-day mortality between a hematocrit of 24% versus 30% in this setting. 3. Anesthetic management for AAA repair, tailoring the approach.
It's clear that managing the patient during these surgeries is a huge undertaking. What are the anesthesiologist's main goals?
The primary objectives are several-fold. Provide optimum analgesia, pain relief, and amnesia, lack of awareness. Facilitate surgical relaxation, maintain hemodynamic stability that's stable blood pressure and heart function, preserve renal blood flow, and ultimately minimize overall morbidity and mortality. Critically, no single anesthetic technique has been definitively proven superior to others.
So it's more about the management.
Exactly. Balancing these objectives, like maintaining consistent hemodynamic control and avoiding significant hypertension or hypotension, is vital for oxygen delivery to organs, decreasing myocardial oxygen consumption, and preventing complications like hemorrhagic stroke. With general anesthesia, circulatory stability is especially desirable, particularly for patients with coexisting coronary artery disease. Inhalation anesthetics can depress the myocardium and cause hemodynamic instability, so high concentrations are usually avoided in patients with moderately to severely decreased ejection fraction, though lower concentrations are acceptable. They do have beneficial effects, though, altering autonomic responses, reversibility, rapid emergence, potentially allowing earlier extubation, and maybe even some neurologic and cardiac protection. Opioids are attractive for patients with ischemic heart disease or ventricular dysfunction because they provide cardiovascular stability and intense analgesia. They cause sympathetic nervous system inhibition, which can decrease SVR and heart rate, so careful titration is key. Dexmedetomidine is another option, valued for its sympatholytic effects, calming the stress response, lack of respiratory inhibition, and postoperative analgesia.
What about regional anesthesia, like an epidural? When is that used, and what are its pros and cons?
Epidural anesthesia is commonly considered for abdominal aneurysmectomies due to its numerous potential benefits. Benefits include decreased preload and afterload, reducing strain on the heart, potentially preserved myocardial oxygenation, a reduced stress response, excellent muscle relaxation, decreased incidence of postoperative thromboembolism, blood clots, increased graft flow to the lower extremities, decreased pulmonary complications, and improved postoperative analgesia. Some studies even suggest a decreased rate of postoperative MI.
Sounds pretty good. What are the risks?
Potential disadvantages include the risk of epidural hematoma, a blood clot near the spinal cord, especially with anticoagulation, which can be catastrophic. And severe hypotension can occur, particularly during significant blood loss or upon unclamping, which can be difficult to manage. A combined general and epidural technique aims to offer the benefits of both. You get the amnesia and controlled ventilation of general anesthesia, but the neuraxial blockade allows for a light general anesthetic. Postoperatively, epidural analgesia improves respiratory function and blood flow to distal tissues, and it reduces postoperative pain and pulmonary complications, especially in patients with COPD after open aneurysm repair. However, the major risks associated with neuraxial anesthesia remain: subarachnoid or epidural hemorrhage, especially after heparinization, and hypotension that can be challenging to treat during acute blood loss.
So there's no single best anesthetic for these surgeries.
That's right. All these techniques, general, regional, or combined, can be used safely and yield positive outcomes. However, what's more important than the specific technique is the clinical management of each patient. Vigilant observation, accurate interpretation of the monitoring data, and immediate intervention to minimize dramatic hemodynamic variability during the anesthetic process are what truly reduce morbidity and mortality. It's also worth noting that inhalation and intravenous anesthetic agents can decrease oxygen demand and potentially protect neurologic and cardiac tissue in non-cardiac surgery settings like this. Maintaining intravascular volume is an extreme challenge, as we've discussed. There's ongoing debate about whether crystalloids or colloids significantly affect overall morbidity and mortality. Generally, initial blood losses can be replaced with crystalloids, using a 3.1 ratio for replacement, or a combination of crystalloids and colloids. Volume replacement must always be dictated by physiologic parameters, things like cardiac filling pressures, cardiac output, and aiming for a urine output of at least 1 LOK-GHR.
Can you give too much fluid?
Absolutely. Hypervolemia can lead to congestive heart failure, especially in patients with limited cardiac reserve. That's why we rely on robust access, cell saver, 2 large-bore IVs, a central venous catheter, and increasingly use goal-directed fluid therapy, using monitoring to optimize intravascular volume and hemodynamic status precisely.
Are there particular moments in the surgery when hemodynamic changes are especially likely?
Yes. Fluctuations in heart rate and blood pressure are highly anticipated during induction of anesthesia and intubation. Adequate preoperative sedation helps blunt this response before we even place invasive monitors. Replacing any preoperative fluid deficit is key to preventing exaggerated responses to vasodilating induction agents. For patients with good left ventricular function, stability can often be maintained with a slow and controlled induction using higher doses of opioids and having sympathomimetic agents ready if hypotension develops. And remember the mesenteric traction response. That can also trigger the celiac reflex, leading to bradycardia and hypotension. And the care doesn't stop when the surgery ends. Postoperatively, patients face significant risks. Cardiac, respiratory, and renal failure are the most common complications. Cardiovascular function must be closely monitored in the ICU for at least 24 hours. Maintaining adequate blood pressure, intravascular fluid volume, and myocardial oxygenation is paramount. MI is a frequent contributor to morbidity and mortality, necessitating serial cardiac enzyme analysis. Pharmacologic agents for hypertension or hypertension must be readily available.
Most patients require ventilatory assistance initially, and vigilant respiratory monitoring is mandatory, especially if epidural catheters are in use for pain control. It requires intensive and continuous assessment, covering a whole range of potential issues, continuing invasive hemodynamic monitoring, treating acute BP extremes and arrhythmias, assessing for MI, providing ventilatory management including weaning and extubation, assessing for abdominal compartment syndrome, evaluating blood counts, coagulation status, volume adequacy, kidney function, B1 creatinine urine output, and instituting DVT prophylaxis. 4. Juxtarenal and suprarenal aortic aneurysms. Proximal challenges.
So far, we've talked broadly about AAAs, mostly infrarenal ones. But what happens when the aneurysm is higher up, near the kidneys, or even higher in the abdomen?
Right. While most AAAs are infrarenal below the kidney arteries, about 2% extend proximally to involve the renal or even the visceral arteries, like those supplying the gut. This distinction is critical. Juxtarenal aneurysms are right at the level of the renal arteries, but spear their openings, their orifices. Suprarenal aneurysms are even higher, including at least one renal artery and potentially involving visceral vessels. The effects of aortic cross-clamping are generally similar to infrarenal occlusions, but the magnitude of hemodynamic alterations increases significantly as the clamp is positioned more proximally.
So bigger swings in blood pressure, more stress.
Exactly. And renal failure occurs more often with suprarenal aortic occlusion than infrarenal, simply because the blood flow to the kidneys is more directly impacted or completely stopped. While maintaining adequate intravascular volume and administering osmotic and loop diuretics may minimize renal ischemia and dysfunction, their scientific efficacy for actual preservation or improvement is not fully proven, as we discussed. Aggressive hemodynamic support and minimizing clamp time remain key. Paraplegia, as we mentioned, becomes a significant concern when the blood supply to the spinal cord is interrupted by cross-clamping at or above the diaphragm. Strategies to increase spinal cord perfusion pressure include increasing MAP or decreasing cerebrospinal fluid, CAT-TF, by draining CSF through a subarachnoid catheter placed before surgery. Total body hypothermia and neurologic monitoring, SSPs and MEPs, can also decrease paraplegia incidence. Early detection and intervention for spinal cord ischemia are crucial, especially since neurologic deficits can sometimes appear weeks after surgery, not just immediately. Routine SFP monitoring, serial neurologic assessment post-op, arterial pressure augmentation, keeping EP up, and CSF drainage can benefit at-risk patients. Potential complications of juxtarenal suprarenal occlusion are extensive. Renal failure, hemorrhage, distal arterial occlusion or infarction, pulmonary cardiac dysfunction, impotence, paraplegia, thrombosis, pseudoaneurysm formation, and aortic enteric fistula, a connection between the aorta and gut. 5. Ruptured abdominal aortic aneurysm, RAA.
What about a ruptured AAA? That sounds like a true medical emergency.
It absolutely is. A ruptured AAA carries an extremely high mortality rate, maybe 80% to 90% overall, considering those who don't even make it to the hospital. Even for those who get to surgery, the postoperative mortality is estimated at 40% to 50%.
And does the type of repair matter then? Open versus endovascular?
Tragically, the repair type, open versus endovascular, doesn't seem to significantly change the post-surgical mortality rate in the setting of rupture. The critical factor is that the rupture itself has occurred, leading to massive hemorrhage and shock. The most common symptoms form a classic triad: severe abdominal discomfort or back pain, an altered level of consciousness caused by hypotension, low blood pressure, and a pulsatile abdominal mass felt on exam. Other common symptoms include syncope, fainting, groin or flank pain, hematuria, blood in urine, and sometimes even a groin hernia.
Are there factors that make the outlook even worse?
Yes. Risk factors associated with increased mortality in this emergency include increased age, female gender, non-white race, insurance status, unfortunately higher for self-pay Medicaid in the U.S., and comorbid conditions like congestive heart failure, renal failure, and valvular heart disease. But hypotension and a history of cardiac disease are associated with the poorest prognosis.
So if a patient comes in with these symptoms, what's the immediate action?
Patients presenting with these symptoms should be immediately transferred to the operating room for surgical exploration. No delay. If hypotension is absent, there might be a fraction more time for assessment, but rapid decompensation is always a looming threat. In the operating suite, the absolute priorities are establishing peripheral and central venous access for rapid, massive fluid and blood product administration. Blood salvaging techniques and the ability to rapidly infuse are essential. Insertion of an arterial line is critical for monitoring the significant blood pressure fluctuations. Vasopressors, like phenylephrine, epinephrine, must be immediately available. Hemodynamic stability is the primary objective, and anesthetic induction and maintenance agents are selected very carefully on a case-by-case basis, considering the patient's extreme instability. Cardiovascular stability is paramount until the proximal aortic bleeding is surgically controlled by clamping. Fluid resuscitation begins with crystalloids. Colloids and blood products are administered as rapidly as available. Intraoperative blood salvage should absolutely be used. Coagulation studies, hemoglobin, hematocrit, ionized calcium, clotting factors, are obtained urgently. Large amounts of citrate anticoagulant in banked blood bind calcium, causing relative hypocalcemia. This can lead to decreased myocardial contractility, causing hypotension, increased heart filling pressures, and increased bleeding. So calcium chloride is administered as guided by ionized calcium levels.
Yeah, clotting issues.
Dilutional thrombocytopenia, low platelets, is the most common cause of coagulopathy after massive fluid and blood administration. Fresh frozen plasma helps decrease total transfusion needs and address these coagulopathies by replacing clotting factors. The hemodynamic effects of aortic cross-clamping and release are similar to elective surgery, but can be extreme in a rupture scenario, especially if profound hypotension is present when the clamp is released. Most patients require huge amounts of fluid and blood, making postoperative mechanical ventilation almost always necessary. Patients in hypovolemic shock are extremely sensitive to the myocardial depressant and vasodilatory effects of anesthetic agents, warranting very careful titration and the liberal use of vasopressors and positive inotropes. Ventilation itself can be difficult due to cephalad diaphragm displacement from the retroperitoneal hematoma, decreasing lung expansion and functional residual capacity, and increasing peak airway pressures. Positive pressure ventilation can also decrease venous return, worsening hypotension.
We try to minimize peak inspiratory pressures, administer higher oxygen concentrations, and use manual positive pressure breaths to improve alveolar recruitment. 6. Thoracic aortic aneurysms, TAA.
Shifting our focus now to aneurysms higher up in the chest, above the diaphragm. How dangerous are these?
Thoracic aortic aneurysms, TAAs, are indeed very dangerous. The mortality associated with elective thoracic aneurysm repair is around 22%, which is significantly higher than for AAAs. And if a TAA ruptures, the mortality increases to about 54%. Aortic dissections, those tears in the aortic wall, are particularly lethal. If untreated, the predicted survival is only about 3 months due to the extremely high risk of rupture.
So the stakes are even higher here.
Definitely. While aneurysms have been described for centuries, successful surgical bypass options only really emerged in 1951 with the development of the arterial prosthesis. Since then, refinements in endovascular stent grafts, surgical perfusion techniques, and intraoperative management have significantly improved outcomes, but it remains a high-risk area. Thoracic aneurysms are classified by type, shape, and location, similar to but distinct from AAAs. You have true aneurysms involving all 3 arterial wall layers versus false aneurysms, pseudoaneurysms, involving only the adventitia, often from a contained leak. Shapes include fusiform, that's spindle-shaped dilation, common in the descending distal thoracic aorta, often atherosclerotic, and saccular, more spherical, limited to one vessel segment.
And dissection is different again.
Yes, aortic dissection is a spontaneous tear in the intima, the inner layer, allowing blood flow into a false passage along the aorta's longitudinal axis. This dramatically weakens the wall and makes surgical repair, like graft isolation, very difficult. There are 2 major classification schemes for aortic dissections you should know. DeBakey, type 1, ascending, extending to arch descending. Type 2, confined to ascending. Type 3, descending only, distal to left subclavian. And Stanford, type A, involves ascending aorta. Type B does not involve ascending aorta. Stanford type A is generally a surgical emergency.
Okay, DeBakey and Stanford.
Right. And then thoracoabdominal aortic aneurysms, TAAs, which involve both the chest and abdomen, are classified using the Crawford classification. Type I through V, based on the extent from the subclavian artery down towards the iliac bifurcation. While atherosclerosis is the most common cause, especially for descending TAAs, there are other important etiologies for thoracoabdominal aortic aneurysms. These include degenerative changes, which are nonspecific, dysplastic, making up about 80%, mechanical or hemodynamic causes like previous dissections, post-stenotic dilation, trauma, connective tissue disorders, Ehlers-Danlos, Marfan syndrome, inflammatory or non-infectious conditions, Takayasu arteritis, Behçet disease, Reiter syndrome, Kawasaki disease, polyarteritis nodosa, ankylosing spondylitis, rheumatoid aortitis, infectious causes, tuberculosis, bacterial, fungal, spirochaetal, and even issues related to previous surgery like anastomosis breakdown or pseudoaneurysm formation.
How do these higher aneurysms present? Are there specific symptoms related to their location in the chest?
Symptoms often relate directly to the lesion site and its compression of adjacent structures. Pain is common. Stridor, noisy breathing, and cough can result from thoracic structure compression, like the trachea or bronchi. Hoarseness can occur from impingement on the left recurrent laryngeal nerve, which loops under the aortic arch. That's a classic sign sometimes. Aortic insufficiency symptoms, like shortness of breath, fatigue, may be observed with ascending aorta aneurysms affecting the aortic valve.
Can they be found incidentally?
Yes, sometimes an upper mediastinal mass might be an incidental finding on chest radiography in asymptomatic patients, prompting further investigation with non-invasive methods like CT scans and MRI to define specific anatomic characteristics and location. Due to the high mortality of thoracic aneurysm rupture, early detection and surgical intervention significantly contribute to long-term survival. Hemodynamic compromise, like shock, and increased aneurysm complexity lead to increased postoperative mortality. The surgical approach varies considerably by the lesion's location within the thoracic aorta.
Can you give some examples?
Sure. For the ascending aorta and graft replacement, this often requires complete or partial cardiopulmonary bypass. We might use atrial femoral bypass, where blood is drained from the left atrium, pumped externally, and reinfused into a femoral artery. If full bypass isn't used, heparin, 50 to 100 units needed before clamping. For complete bypass, total systemic heparinization, around 400 units, and activated clotting time, ACT monitoring, are necessary. Sometimes the aortic valve needs replacement too. Transverse arch lesions are particularly tricky because they compromise cerebral perfusion. Various complex bypass techniques combined with profound hypothermia and circulatory arrest, stopping blood flow entirely for a period, are often used.
Wow, circulatory arrest.
Yeah, it's complex. For descending aorta aneurysms, these can sometimes be resected after aortic cross-clamping. But distal organ perfusion, kidneys, spinal cord, gut, can be compromised. For monitoring, we often use a right arterial line and pulse oximetry because the left subclavian artery might be involved or clamped. A double lumen endotracheal tube is usually placed to allow deflation of the left lung, improving surgical exposure and avoiding lung contusion. The patient is positioned in left lateral decubitus and a left-sided thoracotomy incision is made. 7. Descending thoracic and thoracoabdominal aneurysms, DTISA, deeper the complexities.
These DTAAs and TAAs sound like the most challenging of all. What kind of patients are we talking about? How do you prepare them?
You're right, they are incredibly complex. Patients undergoing major vascular surgery for these are often elderly, with varying degrees of concurrent disease. Again, systemic atherosclerosis is common. Most patients with DTAs are actually asymptomatic until the aneurysm is quite large. Operative decisions are based on aneurysm size, extent, and its rate of expansion. For degenerative aortic disease, repair is generally advised for aneurysms 6 centimeters or larger. Independent risk factors for poor outcomes include existing pain, increased age, COPD, renal insufficiency, the size of the aneurysm itself, and how quickly it's growing.
So the preoperative assessment must be incredibly thorough.
Absolutely. A thorough preoperative evaluation cannot be overemphasized, with special attention to cardiac, renal, and neurologic function. Most fatalities are cardiac-related, but renal and neurologic dysfunction greatly contribute to poor outcomes. Preoperative renal dysfunction is strongly linked to postoperative renal failure. Neurologic function must be carefully assessed, noting any lower extremity dysfunction, because paraplegia is such a devastating potential consequence. Even hoarseness from recurrent laryngeal nerve compression, the left nerve is most susceptible due to its path near the aortic arch, should be documented, as bilateral damage can cause severe respiratory compromise post-op. Intraoperative monitoring devices for DTITA are similar to those for abdominal aneurysmectomies, but with key adaptations due to the location complexity. Direct intraarterial blood pressure and pulmonary artery pressure monitoring are standard, especially if extracorporeal circulation bypass is used. If the aneurysm involves the thoracic region or distal aortic arch, a right radial arterial line monitoring is preferred due to potential compromise of left subclavian arterial blood flow.
T is strongly suggested for cardiac monitoring, especially in patients with myocardial dysfunction. An indwelling urinary catheter assesses renal function. A double lumen endotracheal tube allows one lung ventilation, requiring careful oxygenation monitoring. Pulse oximetry often placed on the right hand, ear, or nose if the left subclavian is manipulated. A lumbar intrathecal catheter is often inserted for CSF pressure monitoring and drainage. And SAPs and/or MEPs are frequently used for real-time detection of neurologic dysfunction.
That spinal cord risk is terrifying. How often does that happen, and what's being done to prevent it?
Neurologic dysfunction is a very serious complication. The incidence of immediate paraplegia ranges widely, from near 0% with short clamp times or adjuncts up to 7% on average for TA repair, but reported ranges go as high as 0.32%. It's highly variable. Impending injury risk depends on aneurysm type. Crawford classification matters, surgical technique, cross-clamp time, and the use of spinal cord protection interventions. And remember, delayed paraplegia is believed to affect up to 25% of all spinal cord injuries after these procedures.
What increases the risk of delayed paraplegia?
Primary preoperative risk factors include type 2 aneurysms, extensive thoracoabdominal, emergency procedures, the number of sacrificed segmental arteries supplying the cord, and renal failure. Main postoperative factors include hemodynamic instability, like atrial fibrillation developing, bleeding, multi-organ failure, and sepsis. Several successful techniques are used to decrease neurologic dysfunction. We've mentioned SSEP MAP monitoring and CSF drainage. Hypothermia, mild systemic or even selective spinal cord cooling, may lengthen ischemic tolerance time, though clinical benefits aren't definitively proven. Reattachment of critical intercostal arteries during the repair is ideal if possible. Distal aortic perfusion techniques or bypass shunts aim to minimize aortic occlusion time.
How does CSF drainage help exactly?
Spinal cord perfusion pressure can be estimated as arterial blood pressure minus CSF pressure. During aortic clamping, CSF pressure tends to increase while arterial pressure distal to the clamp decreases, squeezing the cord's blood supply. Manipulating spinal cord perfusion pressure involves altering arterial blood pressure, keeping MAP 90 mmHg, and draining CSF, aiming for a pressure of 10 mmHg. Other key interventions include routine CSF drainage, potentially using naloxone infusion, endorphin receptor blockade, theories it reduces edema, moderate intraoperative hypothermia, 35 degrees C, avoiding hypotension, and optimizing cardiac function. We also avoid sodium nitroprusside for blood pressure control, as it can cause a steal phenomenon, dilating other vessels and potentially shunting blood away from the already compromised spinal cord.
Does the monitoring guarantee safety?
Unfortunately, while SEP-MEP monitoring provides early identification, they don't guarantee spinal cord integrity. Factors contributing to deficits are multifactorial: clamp level, ischemic time, embolization or thrombosis of critical intercostal arteries, failure to revascularize segments, and surgical urgency. Delayed paraplegia might also result from IRI, ischemic reperfusion injury, though the exact mechanism is still debated. Complications after DTATAR repair are numerous: respiratory failure, most common, hemorrhage, MI, CHF, early or delayed paraplegia, embolization thrombosis, distal artery occlusion, bowel ischemia, sexual dysfunction, infection, renal failure, and CVA stroke. The principles of anesthetic management for TAs and DKAs mirror those for AAAs, but everything is intensified. Anesthetic selection is based on concurrent disease, always aiming for cardiovascular stability and minimizing morbidity mortality. Intraoperative monitoring focuses intensely on myocardial, neurologic, and renal ischemia detection. Hemodynamic consequences of cross-clamping must be aggressively attenuated with the pharmacologic adjuncts. Restoring circulating blood volume before clamp release is critical.
So a patient gets through this massive surgery. What's the recovery like, and what are the ongoing concerns?
Postoperatively, if a double lumen endotracheal tube was used, it's typically replaced with a standard one, as ventilatory assistance is usually required for some time. Airway edema can make reintubation difficult, so sometimes the double lumen tube might be left in place until edema dissipates. Recurrent laryngeal nerve dysfunction can lead to breathing difficulties after extubation. Close observation of neurologic, circulatory, pulmonary, and renal status is warranted in the ICU. Hemodynamic control is vital to maintain organ perfusion without overstressing the heart or the aortic graft. Careful respiratory monitoring, aided by arterial blood gas analysis, is indicated. Epidural analgesia, using local anesthetics, narcotics, or both, provides excellent pain relief and can facilitate breathing exercises. 8. Endovascular aortic aneurysm repair, EVRR. The minimally invasive revolution.
Okay, let's shift gears. This is the game changer, right? The less invasive option, EVR.
Absolutely. Endovascular aortic aneurysm repair, or EVAR, represents a true revolution in vascular surgery. The first procedure for infrarenal aortic aneurysms was performed back in 1991. It offers a less invasive repair method, and it was initially developed for the roughly 30% of patients with aortic aneurysms who were considered poor surgical candidates for open repair due to severe cardiac and respiratory pathology. Today, EVAR is the treatment of choice for the majority of patients with a AAA.
How does it stack up against open surgery, OSR?
EVAR is associated with significantly improved 30-day outcomes compared to OSR. We typically see lower overall mortality, for example, maybe 1.7% in EVAR versus 4.7% in OSR in major trials, reduced readmission rates, fewer surgical site infections, less pneumonia, and less sepsis. EVAR usually involves decreased procedure duration, a reduced need for blood transfusions, shorter hospitalization, like 5.8 days versus 11.9 days for OSR in some studies, and decreased overall morbidity. Randomized trials like EVAR-1, DREAM, and OVER have consistently shown lower 30-day mortality rates for EVAR.
That sounds significantly better short term.
It is. For thoracic aortic aneurysms, TVAR, EVAR also shows a low incidence of spinal cord ischemia, maybe 0.6%, and paraplegia, likely due to the absence of thoracic aortic cross-clamping and prolonged extreme hypotension. EVAR has also improved survival rates for ruptured AAAs compared to historical open repair outcomes for rupture.
But you mentioned trade-offs.
Yes, it's not without its trade-offs. While early mortality is lower, long-term mortality rates, say at 24, 36 months post-op and beyond, seem to be similar for EVAR and OSR. Reinterventions are more frequent after EVAR, primarily due to endoleak, which we'll get into. The overall risk of late failure is around 3% per year. One large comparison involving nearly 40,000 patients showed EVAR had lower perioperative mortality and lower mortality at 3 years, but similar mortality at 3+ years compared to OSR. Follow-up interventions were definitely more common after EVAR, mostly for endograft issues, and perhaps surprisingly, the risk of aneurysm rupture was greater with EVAR within an 8-year postoperative period in that study.
So higher reintervention and late rupture risk.
Potentially, yes. The intensive follow-up required, the possibility of reinterventions, and the cost of the endograft itself often make EVAR more expensive than open repair over the long term.
So it's better short term, but the long-term picture becomes more nuanced. What exactly happens during EVAR?
Precisely. It's a balance. The most significant intraoperative advantages of EVAR over OSR are the absence of aortic cross-clamping and avoiding that large incision from saphoid to pubis. EVAR involves deploying an endovascular stent graft, EVSG, within the aortic lumen using catheters. The idea is to exclude the aneurysm sac from blood flow and pressure. This technique is also used for TAAs and TAA, then called TVAR or complex EVAR. The procedure involves cannulating usually both femoral arteries in the groin. A guide wire is threaded through the iliac artery up to the aneurysm level using fluoroscopy, live X-ray. A delivery sheath is inserted over the wire. The proximal end of the deployed graft must land in healthy aorta above the aneurysm, taking great care to avoid occluding the renal arteries. Once deployed, the stent graft's radial force or specific fixation mechanisms like hooks or barbs embedded into the aortic wall to prevent migration.
Where is this done?
It can be done in a traditional operating room, a hybrid OR with advanced imaging, or an interventional radiology suite. Systemic anticoagulation with heparin, usually 5,100 units Ks, is administered before catheter manipulation, and broad-spectrum antibiotics are recommended pre-surgery. For EVAR anesthesia, local anesthesia at the femoral insertion site with minimal sedation is actually the most common technique used worldwide now, along with antithrombotic therapy and observation for hypotension and bradycardia.
Why local?
Anticoagulation with a heparin bolus, 5,100 units Gray, maintains an activated clotting time 250 seconds. Local anesthesia with sedation is associated with decreased non-fatal cardiac morbidity, fewer respiratory complications, less renal failure, and lower overall mortality, as well as shorter length of stay. While some studies show no difference in 30-day mortality between local and general anesthesia for EVI, local anesthesia is consistently linked to shorter operative times, hospitalization, and fewer complications. Other anesthetic options include general anesthesia and neuraxial blockade, spinal or epidural. The goals remain maintaining hemodynamic stability, providing analgesia and anxiolysis, and being prepared for rapid conversion to an open procedure if necessary. Interestingly, EVAR patients release less plasma cortisol and may have reduced sepsis and systemic immune response syndrome compared to OSR patients.
Can EVAR still affect the kidneys?
Yes. Even with EVAR, creatinine clearance can decrease by about 10% in the first year. Proximal EVSG migration can occlude renal arteries and cause postoperative renal failure. Special fenestrated EVSGs, with custom holes for the renal arteries or branched grafts, are now safely used for juxtarenal or suprarenal aneurysms to preserve renal artery flow during endovascular repair.
The technology here sounds fascinating. What are these grafts actually made of?
Endograft design and durability are continuously improving. Devices can be unibody, one-pieced, or modular, multiple pieces assembled inside the body. The fabric is typically either woven polyester, Bacron, or expanded polytetrafluoroethylene, EPTFE, with no significant difference noted in biologic response. The supporting skeleton, the stent structure, is made of stainless steel, nitinol, a nickel-titanium alloy popular for its shape memory and minimal shortening, or elginoy, a cobalt-chromium alloy. Drug-eluting stents, which release medication to prevent scarring, show improved restenosis rates in initial trials, though mainly studied in smaller arteries so far. EVSGs have evolved significantly to meet complex anatomic challenges, making endovascular repair possible now for many thoracoabdominal and juxtarenal aneurysms, which were previously limited almost exclusively to open surgery. Fenestrated and branched EVSGs are proving safe and effective in short to midterm follow-up.
You mentioned endoleaks as a key issue. Can you elaborate?
Yes, a serious complication specific to EVAVER is endoleak. This refers to persistent blood flow and pressure, sometimes called endotension, between the endovascular graft and the aortic aneurysm sac wall. It means the aneurysm isn't completely sealed off and remains pressurized. Endoleaks are diagnosed by postoperative CT scans in a significant percentage of patients, maybe 15% to 52% depending on the study and timing. They are classified by type.
Okay, what are the types?
Type I is an attachment site leak, either at the top proximal or bottom distal end of the graft. These are considered dangerous because they allow systemic pressure directly into the sac. Treatment usually involves reinforcing the seal with graft extensions, placing a secondary endograft, or converting to open repair. Type 2 is a branch leak, where blood flows backward into the sac from collateral arteries like lumbar arteries, the inferior mesenteric artery, or internal iliac arteries. This is the most common type, and fortunately about 70% close spontaneously within the first month. We monitor them for aneurysm sac enlargement. If it grows, treatment might involve laparoscopic clipping of the feeding vessel or catheter-based embolization.
Okay, types 1 and 2. What else?
Type 3 is a graft defect, like a fabric tear or a disconnection between modular components of the graft. These also allow high pressure into the sac and require treatment, usually with secondary endograft or open repair. Type 4 relates to graft wall fabric porosity or leaks through suture holes in older generation grafts, usually treated with observation unless significant, then possibly open repair. And finally, there's endotension, where there's measurable pressure in the aneurysm sac despite no visible evidence of endoleaks on imaging. The cause isn't always clear, but it implies continued risk. Treatment often involves relining with a secondary endograft or open repair.
So endoleaks are common and need management.
They are relatively common, yes. The EVR1 study showed reinterventions due to endoleak were 3 times more frequent than complications requiring reintervention after open procedures, around 7% within 1 month, 13% within 4 years. Endoleaks, particularly type I and 3, are the most likely cause of late aneurysm rupture after EVR.
Which explains the need for lifelong surveillance.
Exactly. This leads us to why post-EVR surveillance is so critical. It's essential for detecting these issues early and avoiding late aneurysm rupture. Many late ruptures, if caught early due to surveillance detecting an endoleak or sac growth, are actually treatable endovascularly. Lifelong radiographic evaluation and surveillance are necessary to monitor aneurysm size, graft position, migration, and for endoleaks. Physical exams and contrast-enhanced CT scans are typically recommended at 1, 6, 12, and 18 months postoperatively, then annually thereafter. Abdominal x-rays are also obtained regularly to check the stent structure.
So even with a less invasive procedure, the follow-up commitment is quite significant. 9. Cerebrovascular insufficiency and carotid endarterectomy, CEA, protecting the brain. Now, let's pivot to the brain's blood supply. We're talking about the carotid arteries, which seems like a whole different level of precision is required.
You're absolutely right. Protecting the brain during intervention is paramount here. Carotid endarterectomy, or CEA, is actually the second most common vascular operation in the U.S., right after coronary artery bypass grafting, CBG. And cerebrovascular accidents, CVAs, or strokes, are the third leading cause of death, with most being ischemic caused by a lack of blood flow rather than hemorrhagic bleeding.
How does carotid disease cause stroke?
In carotid atherosclerotic disease, it's those same subintimal fatty plaques growing, but this time in the major arteries supplying the brain. They incrementally occlude the vessel lumen, decreasing cerebral blood flow, CBF. The plaque can also rupture, releasing fibrin, calcium, cholesterol, and inflammatory cells. This can lead to abrupt lumen occlusion from thrombosis, platelet activation causing a clot right there, or an embolus, debris traveling downstream. Both scenarios cause an abrupt decrease in CBF, resulting in transient ischemic attacks, TIAs, often called mini-strokes or full-blown strokes. More than half of all strokes are preceded by a TIA, making them crucial warning signs. The famous Framingham study reported a 30% stroke risk within 2 years after a TIA and approximately 55% risk after 12 years. This significant increased risk is the primary rationale for performing CEA,
And CEA is?
CEA is a surgical procedure where the internal carotid artery is carefully incised, and the atherosclerotic plaque is meticulously removed to improve CBF and, most importantly, prevent future strokes.
So who actually needs this surgery? Is it for anyone with carotid stenosis, narrowing?
The indications have been debated since the procedure was developed in 1954, but large, well-designed clinical trials have largely clarified this. Initially, it was mainly for symptomatic stenosis, patients who had a TIA or minor stroke related to that artery, provided the artery wasn't completely occluded. Some centers expanded indications cautiously to include patients with evolving strokes or certain asymptomatic patients.
What's the big trials?
NASCET, North American Symptomatic CEA Trial, was key. For symptomatic patients with high-grade stenosis, 70–99%, CEA showed a huge 65% risk reduction for ipsilateral stroke on the same side, 2 years post-surgery compared to medical management alone. ACA's asymptomatic carotid atherosclerosis study looked at asymptomatic patients with at least 60% carotid artery stenosis. It found that those undergoing CEA had a 53% lower 5-year risk of ipsilateral stroke than medically treated patients. And ECAST, European Asymptomatic Carotid Surgery Trial, showed similar benefits of CEA plus medical therapy over medical therapy alone for 60–99% stenosis, roughly a 5% absolute risk reduction, or 50% relative stroke risk reduction at 5 years.
So benefit in both symptomatic and asymptomatic, but maybe greater in symptomatic.
Exactly. Symptomatic patients are at higher risk for perioperative adverse events from the surgery itself, but the benefit of CEA in those with recent ipsilateral carotid territory symptoms and moderate to severe stenosis is much greater than the benefit seen in asymptomatic patients.
What are the risks of the surgery itself?
Surgical outcomes vary due to patient populations and surgical expertise, of course. Other unstratified variables include collateral flow through the circle of Willis in the brain, concurrent cerebral atherosclerotic disease elsewhere, plaque size and morphology, presenting symptoms, and concurrent cardiovascular disease. Remember, carotid artery stenosis causes about 20% of all strokes. Generally accepted perioperative stroke rates are less than 3% in asymptomatic patients, less than 5% in symptomatic patients, and maybe less than or equal to 10% in patients with recurrent disease or existing strokes. Reported rates from experienced centers often meet or fall below these limits.
What about heart attacks during CEA?
That's a key point. The perioperative MI rate is around 2 to 5%, and this is actually the greatest contributor to overall morbidity after CEA, highlighting again the global nature of atherosclerosis. Perioperative mortality, death, is quite low, approximately 0.5–2.5%. Long-term postoperative stroke incidence is about 1–3% per year. Stroke incidence and mortality trends in the U.S. have shown decreases over recent decades.
How is the decision made whether to operate?
The decision to undergo CEA involves carefully weighing the surgical risks against the risks of medical management alone, stroke risk from the untreated stenosis. Patients benefiting most are clearly those symptomatic patients with 70% stenosis. It's considered less beneficial, but still potentially indicated, for symptomatic patients with 50–69% stenosis. Surgical intervention appears most beneficial for men over 75 years old who are within 2 weeks of their last ischemic event. Preoperative neurologic dysfunction is the most significant predictor of postoperative stroke incidence, around 4%. Conditions increasing perioperative complication risk include severe preoperative hypertension, needing CEA just before CAB, angina, stenosis near the carotid siphon, higher up in the skull, age 75 years, and diabetes mellitus.
What about operating soon after a stroke?
Historically, emergent CEA, or carotid artery stenting, CAS, after an acute CVA was not considered safe due to risks like hemorrhagic conversion. However, more recent evidence suggests these interventions, even within 72 hours after TPA, clot-busting drug for thrombolysis, can potentially reduce neurologic damage and recurrent stroke without significantly increased complications in carefully selected patients. That's still evolving.
How do doctors find carotid stenosis? What are they looking for symptom-wise?
Neurologic symptoms like lightheadedness, altered consciousness, aphasia, difficulty speaking or understanding language, and acute motor deficits often relate to decreased CBF and warrant testing for carotid stenosis. An asymptomatic carotid bruit, that whooshing sound heard with a stethoscope, can indicate disease but doesn't always correlate with significant stenosis. A classic symptom is amaurosis fugax, or transient monocular blindness like a curtain coming down over one eye. This occurs in about 25% of patients with high-grade stenosis and is believed to be caused by microthrombi or plaque debris migrating from the internal carotid artery into the ophthalmic artery supplying the eye.
What imaging is used?
Standard diagnostic imaging includes duplex ultrasonography, combining ultrasound imaging and Doppler flow measurement, digital subtraction angiography,
DSA, though less common now due to invasiveness, CT angiography, CTA, and magnetic resonance angiography, MRA. Ultrasound is often the first step, with CTA or MRA used for confirmation and detailed planning. The presence of concurrent coronary artery disease, CAD, and carotid stenosis is well documented. As we said, MI contributes more often to poor surgical outcomes than stroke. A systematic approach to identifying CAD and its risks should precede elective surgery, though coronary angiography may not always be justified unless significant symptoms or signs are present. Patients with no significant medical history, normal physical exam, and normal ECG can often proceed directly to surgery, considered low risk. If abnormal cardiac function is found, further evaluation and testing are needed, tailored to the specific comorbidities. Preoperative pharmacologic optimization is crucial. Continuing beta blockers and statins, controlling hypertension, ensuring appropriate anticoagulation or antiplatelet therapy, smoking cessation, evaluating pulmonary renal adrenal function, DVT prophylaxis, musculoskeletal assessment, and glycemic control. Vascular surgery inherently carries an increased risk of major adverse cardiac events, MACE, so guidelines like those from ACC-FAHA for perioperative cardiac assessment are followed.
Safeguarding the brain.
This is such a delicate balance during surgery. How does blood flow to the brain work normally, and how is it maintained during CEA?
Cerebral blood flow, CBF, is remarkably well maintained under normal circumstances. It stays relatively constant across a wide range of cerebral perfusion pressures, CPP, which is basically mean arterial pressure, MAP, minus intracranial pressure, ICP. This is due to cerebrovascular autoregulation, the brain's ability to adjust its own vessel diameter. During CEA, ICP is usually not elevated, so MAP is the main determinant of cerebral perfusion pressure. CBF typically remains constant when MAP is between about 60 and 160 mmHg in a healthy person.
Does hypertension change that?
Yes, chronic systemic hypertension shifts the cerebral autoregulatory curve to the right. This means a higher than normal MAP might be needed to ensure adequate cerebral perfusion in hypertensive patients. Their normal is higher. CBF is also affected by arterial CO2 levels. Hypocarbia, low CO2, causes vasoconstriction, decreasing CBF. Hypercarbia, high CO2, causes vasodilation, which might seem good but can lead to cerebral steal in ischemic areas where vessels are already maximally dilated. Blood flows away from the area that needs it most. Oxygen concentrations also matter, as do anesthetic agents. Most decrease the cerebral metabolic rate of oxygen consumption, CMRO2, offering some protection, with ketamine being a notable exception.
What are the critical flow levels?
Normal CBF is about 50 ml 100 grams of brain tissue per minute. Neuronal function is generally maintained above 25 ml 100 Gmin. Below this, ischemia occurs, often reflected in consciousness changes if the patient is awake. Cellular death occurs below about 6 ml 100 Gmin, which corresponds to a flat EEG. Importantly, in carotid occlusive disease, autoregulation is often disrupted locally or globally, making blood flow much more pressure-dependent. Therefore, a primary goal during CEA anesthesia is to maintain and sometimes actively augment MAP.
How is brain perfusion monitored during the clamping period?
Beyond standard monitoring, continuous direct intraarterial pressure via an arterial line is essential due to the frequent hemodynamic variability and the need for tight blood pressure control. When the carotid artery is cross-clamped, various monitoring techniques are used to assess the adequacy of CBF coming from the other side via the circle of Willis.
Like EEG?
Yes. EEG, electroencephalogram, is considered the gold standard for identifying neurologic deficits related to ischemia. It's reliable for monitoring cortical electrical function. Loss of beta wave activity, loss of amplitude, and the appearance of slow wave activity indicate dysfunction. Limitations are that it's affected by BP, temperature, and anesthetics, and it only detects changes in the superficial brain, cortex.
What about stump pressure?
Carotid stump pressure assesses collateral flow from the non-operative carotid and the basilar artery via the circle of Willis. A small catheter placed in the carotid artery distal to the clamp measures the back pressure. A stump pressure less than 40-50 mmHg is often considered indicative of hypoperfusion and is used by some as a criterion for placing a temporary shunt. However, it doesn't correlate perfectly well with EE changes. For instance, 50 mmHg had only a 36% positive predictive value for EEG ischemia in one study. Combining it with TCD or EEG improves ischemia detection.
Any other methods?
SSEP, somatosensory evoked potential monitoring, identifies inadequate CBF by tracking signals along sensory pathways, but it can have false positives and reflect sensory integrity, so motor deficits can occur with normal SSEPs. There are no definitive values for decreased amplitude or increased latency that perfectly correlate with ischemia. Combining SSF plus EEG monitoring is more sensitive, reportedly 17 times more likely to predict perioperative strokes. TCD, transcranial Doppler, is non-invasive and measures CBF velocity in the middle cerebral artery. It's reliable for determining shunt necessity and may decrease adverse neurologic outcomes. It can also detect microembolic signals and postoperative cerebral hyperperfusion syndrome, CHS, and NIRS, near-infrared spectroscopy, uses light to measure regional cerebral oxygenation, RSO2, non-invasively through the scalp. A reduction of 20% from baseline often correlates with regional or global cerebral ischemia. It's accurate in predicting the need for shunt use, possibly more so than stump pressure alone.
So what can be done to actively protect the brain during this period of decreased blood flow?
The major objective is always to maintain CBF and oxygenation. This is achieved primarily by either increasing collateral flow, usually by placing an intraluminal shunt across the clamped segment during the endarterectomy, or by decreasing cerebral metabolic requirements with specific anesthetic medications. Other interventions include avoiding hyperglycemia, high blood sugar is bad for ischemic brain tissue, hemodilution, though controversial, maintaining normal carbia, normal CO2 levels, and that tight blood pressure control we keep mentioning.
Do anesthetics help protect the brain?
Yes, most anesthetics, except etomidate and maybe ketamine, have cerebral protective properties primarily by decreasing CMRO2, the brain's oxygen demand. Shunt placement allows continuous blood flow across the carotid cross clamp during the plaque dissection. However, shunts have potential complications like traumatic injury to the delicate distal internal carotid artery intima or embolization of atherosclerotic debris or air during placement or removal. The decision to shunt is often based on surgeon preference combined with intraoperative monitoring findings.
When do most ischemic events happen?
Cerebral ischemic events are often embolic in nature and frequently occur postoperatively, not just during clamping. Anesthetics like propofol decrease CMR2, neuroprotective, but can cause myocardial depression and hypotension, requiring careful balance. Inhalation agents also decrease CMRO2 in a dose-dependent fashion, potentially offering anesthetic preconditioning benefits. Nitrous oxide should generally be avoided due to the risk of pneumocephalus, microbubble expansion if air gets trapped, especially after unclamping, and because it can increase hyperhomocystinemia, which is linked to increased postoperative cardiac risk, long-term mortality, and carotid artery restenosis. If used, it should be discontinued before clamp removal.
And blood pressure control is key throughout.
Absolutely. Precise blood pressure control is one of the most challenging aspects of CEA anesthesia due to the high incidence of hypertension and the patient's vulnerability to instability. Hypotension occurs in 10–50% of patients, often due to carotid sinus baroreceptor stimulation during dissection. Conversely, 10–66% experience hypertension, also attributed to surgical manipulation of the carotid sinus. Preoperative BP control, volume status, and anesthesia depth also contribute. During carotid artery cross-clamping, maintaining MAP at 20% or greater of the patient's preoperative mean pressure is thought to decrease postoperative cognitive dysfunction.
How is BP managed?
BP control begins preoperatively. Patients should continue their usual antihypertensives. SBP consistently 180 mmHg increases stroke death risk. Keeping SBP 145 mmHg leads to fewer complications. A postoperative BP target of 480 mmHg or less is often recommended. Pharmacologic agents like short-acting beta blockers, labetalol, esmolol, nitroglycerin, or sodium nitroprusside, used cautiously, manage fluctuations during induction, incision, dissection, carotid sinus manipulation, and emergence. Hypotension specifically from carotid sinus manipulation is treated by asking the surgeon to stop stimulation temporarily, local anesthetic infiltration around the sinus, and anticholinergics like atropine or glycopyrrolate if needed. Anesthetic management for CEA.
So the goals for anesthesia are clear, but how hard is it to hit all those targets simultaneously, protecting the brain, protecting the heart, keeping things stable?
That really is the core challenge. The overall goals are providing analgesia and amnesia, facilitating surgical intervention, and minimizing morbidity mortality. Specific to CEA, the key is maintaining adequate cerebral and myocardial perfusion and oxygenation, minimizing the stress response, and facilitating a smooth, rapid emergence so neurological status can be assessed immediately. The challenge lies in maintaining one system's integrity without adversely affecting another. For example, aggressively raising blood pressure for cerebral perfusion significantly increases myocardial oxygen demand and the risk of cardiac ischemia. So the goal is to find that sweet spot. Optimize brain perfusion, minimize myocardial workload, ensure overall cardiovascular stability, and allow for that rapid emergence.
What about anticoagulation during CEA?
Right. Anticoagulation with heparin, typically 50-100 units array, aiming for an ACT 250 seconds, is given before carotid artery cross-clamping to prevent thrombosis. Protamine administration to reverse heparin post-procedure is based on surgeon preference. Studies suggest protamine reduces bleeding complications without clearly increasing thrombotic outcomes, but it carries its own risks like hypotension and rare anaphylaxis. Understanding cerebrovascular physiology is absolutely crucial for optimal anesthetic management.
What about the choice between regional and general anesthesia? You mentioned trials showed similar outcomes.
Yes, the long-standing question of regional versus general anesthesia for CEA has been widely studied. Major trials like the JLA trial, general anesthesia versus local anesthesia for carotid surgery, and various meta-analyses show no significant difference in major outcomes like death or stroke between the two techniques. So the selection often depends on surgeon preference, patient condition and suitability, and the preoperative evaluation.
What are the specifics of regional anesthesia for CEA?
Regional anesthesia, RA, for CEA usually involves a deep and superficial cervical plexus block, blocking cervical nerves C2, C4, sometimes supplemented with local infiltration by the surgeon, especially for areas like the angle of the mandible covered by the trigeminal nerve. The greatest advantage of RA is the ability to continuously assess neurologic function in an awake patient. Patient responsiveness is considered the most effective and sensitive method for detecting cerebral ischemia during clamping. Some studies suggest fewer perioperative strokes with RA, especially in high-risk patients, and a potentially better preservation of cerebral circulation autoregulation. RA may also lead to less shunting, fewer hemodynamic fluctuations, less need for vasoactive medications, potentially shorter operative times, fewer cardiopulmonary complications, and shorter hospitalization.
What are the downsides of regional?
Limitations include patient anxiety, agitation, or inability to remain still for the duration. There's minimal airway control if something goes wrong. There's a risk of seizure or stroke during clamping if perfusion becomes inadequate. And importantly, the ability to give significant anesthetic or sedative medications is limited because deep sedation can confound the neurologic assessment, negating the primary advantage of RA. Hypoventilation leading to hypercarbia can occur, and dysphoria is more likely. Converting to general anesthesia mid-surgery if needed can be problematic and carries risks. If symptoms of compromised cerebral perfusion occur, dizziness, contralateral weakness, decreased mentation, loss of consciousness, immediate shunt placement is warranted, and emergent airway management may be needed if symptoms don't resolve rapidly with the shunt.
And general anesthesia.
While RA has those advantages, general anesthesia, GA, is also very widely used. Its main benefit is countering the patient tolerance issue of RA, ensuring a completely motionless surgical field, and providing guaranteed airway control. Modern inhalation agents can provide good hemodynamic stability and have beneficial effects on cerebral circulation, decreasing cerebral and cardiac metabolism, that anesthetic preconditioning idea, potentially protecting against ischemia. However, there's no definitive scientific evidence that inhaled agents improve patient outcomes over narcotic-based intravenous techniques for CEI specifically. Isoflurane might allow a lower critical regional CBF before EEG signs of ischemia appear compared to some other agents. Using ultra-short-acting opioids like remifentanil can allow for very rapid emergence and neurologic assessment. A drawback is that inhalation agents can alter EEG monitoring, requiring close communication between the anesthesia and monitoring teams. During unshunted cross-clamping under GA, maintaining MAP at 20% of the preoperative MAP is generally recommended to help ensure adequate cerebral perfusion through the contralateral carotid artery and circle of Willis and may decrease postoperative cognitive dysfunction. And again, nitrous oxide should generally be avoided.
So, wrapping up the anesthetic choice.
In summary, there's no scientific consensus that one specific anesthetic technique is definitively superior in decreasing perioperative morbidity and mortality post-CEA. The most crucial factor is ensuring adequate cerebral and cardiac perfusion by aggressively and proactively treating hypertensive and hypotensive episodes. An anesthetic plan that allows for rapid and reliable assessment of neurologic function at the completion of surgery should be selected, whether that's RA or a well-managed GA with rapid emergence.
What are the most common issues patients face right after CEA surgery?
Postoperative hypertension is perhaps the most common problem, seen frequently in the recovery room. It's likely related to changes in carotid baroreceptor reflex sensitivity after the plaque is removed and the artery is no longer stiffened there. Systolic blood pressure, SPP 180 mmHg, is linked to increased risk of TIA, stroke, or MI, as well as hematoma formation. SBP equals 145 millimilli Hg leads to fewer complications. A postoperative BP target of 440 millimilli Hg or less is often recommended. Hypertension usually resolves within 24 hours but needs active management initially. Postoperative hypotension is less common but can be harder to treat as aggressively raising BP increases myocardial oxygen demand. Careful titration of intravenous fluids and vasopressors is needed.
What about bleeding?
Carotid artery hemorrhage, or neck hematoma, is an uncommon but potentially devastating complication requiring immediate surgical reexploration. The initial manifestation can be upper airway obstruction due to tracheal deviation from the expanding hematoma, making reintubation extremely difficult or impossible. Emergency management involves immediate bedside or OR hematoma evacuation to relieve pressure.
Any other nerve issues or complications?
Yes, nerve damage can occur due to the proximity of cranial nerves. Recurrent laryngeal nerve damage typically presents as hoarseness or, more seriously, inspiratory stridor, which can cause respiratory insufficiency, especially in those with pre-existing lung conditions or if the damage is bilateral. Tension pneumothorax can occur if the lung apex near the surgical site is inadvertently injured. Treatment is immediate lung re-expansion via chest tube or needle decompression. Carotid body dysfunction can blunt the normal chemoreceptor reflex response to hypoxia, sometimes necessitating supplemental oxygen post-op.
And you mentioned cerebral hyperperfusion syndrome. That sounds counterintuitive for a procedure meant to restore blood flow.
It is paradoxical. CHS can result from a sudden dramatic increase in blood flow to a chronically underperfused part of the brain due to a loss of cerebral vascular autoregulation in that area. The exact mechanism is unclear but hypothesized to result from chronic cerebral ischemia leading to impaired autoregulation. When flow is restored, the vessels can't constrict properly, leading to excessive perfusion. Symptoms include severe, often unilateral headache, visual disturbances, altered level of consciousness, and seizures. CHS may occur more often in patients who had a contralateral CEA within the last 3 months and then undergo a second CEA for ipsilateral occlusion, or those with very high-grade stenosis preoperatively. It requires careful blood pressure control and monitoring.
What's a long-term outlook after CEA?
Unfortunately, even after successful revascularization, carotid artery occlusion or significant restenosis can recur at a rate of perhaps 3% per year. While symptoms are present in only a small percentage, maybe 3 to 5% of those with restenosis, the true incidence may be higher as asymptomatic cases might be overlooked without routine follow-up imaging. Neurocognitive decline is also a concern. Up to 25% of patients experience some decline up to 1 month after surgery, particularly those with diabetes and advanced age. The exact mechanism of this postoperative cognitive dysfunction, POCD, is not fully scientifically identified but is likely multifactorial. That's why post-emergence assessment of neurologic integrity is so important, including not just motor sensory function, but also neurocognitive functioning and cranial nerve function, specifically checking facial, glossopharyngeal 9A, vagus X, spinal accessory 11, and hypoglossal nerves due to their anatomic proximity to the carotid arteries during dissection. 10. Carotid artery angioplasty stenting, CAS. The newer frontier.
You've heard a lot about open surgery, CEA, for the carotids. What about stenting, CAS? Is it truly a replacement?
Carotid artery angioplasty and stenting, CAS, is indeed the less invasive endovascular approach. There's been ongoing controversy, really, about its success compared to CEA, and best practices regarding patient selection, technique, and timing are still evolving. As we noted, the current incidence of stroke after CEA in good hands is low, around 2%. A meta-analysis comparing CAS to CEA generally noted that CEA decreases the risk of stroke at 30 days, but might increase the risk of MI with no significant effect on the overall risk of death. It's a trade-off.
What have the major trials comparing them shown?
Several large randomized trials have compared CAS and CEA head-to-head. Sapphire, stenting, and angioplasty with protection in patients at high risk for endarterectomy. This trial focused specifically on patients considered high risk for open surgery. It found non-inferior outcomes for CAS compared to CEA in this group. At 1 year, event-free survival, freedom from death, stroke MI, was actually slightly better for CAS, 88% of 79.9% for CEA. Stroke rates were slightly lower in CAS, 6.2% to 7.9%, and MI rates were notably lower, 1.9% to 6.6% at 30 days. A 3-year follow-up found no significant long-term difference for these high-risk patients when emboli protection devices were used during CAS.
Okay, so CAS looked good for high-risk patients in Sapphire. What about others?
EVA3S, endarterectomy versus angioplasty with symptomatic severe carotid stenosis. This trial focused on standard risk symptomatic patients, 60% stenosis. It was actually stopped early due to a significantly higher incidence of stroke and death in the CAS group, 9.6%, compared to the CEA group, 3.9% at 30 days. The conclusion was that CEA was superior regarding stroke risk in this population at that time, though stent and protection technology has evolved since then. SPACE, stent-protected angioplasty versus carotid endarterectomy, showed high but statistically similar 30-day stroke death rates between the two groups, 6.8% for CAS, 6.3% for CEA. It failed to show non-inferiority for CS based on its primary endpoint. And CREST, carotid revascularization endarterectomy versus stenting trial. This was a very large, well-conducted 10-year trial comparing efficacy in preventing stroke, MI, or death for both symptomatic 50% stenosis and asymptomatic 60% stenosis, standard risk patients. Initial results were encouraging, showing comparable overall outcomes between CS and CEA. The composite endpoint at 30 days was similar.
Did CREST show differences in stroke versus MI?
Yes, CREST confirmed the pattern seen elsewhere. Periprocedurally, CAS had a slightly higher stroke rate, while CEA had a higher MI rate. Interestingly, while initially CS was linked to increased stroke specifically in octogenarians in CREST, further analysis determined that stroke incidence for CS is likely similar across all age groups with current techniques. CREST data also showed better health-related quality of life metrics for CS patients up to 1 year post-procedure. Critically, the 10-year results found no significant differences between CEA and CAS regarding the long-term primary endpoint of stroke, MI, and death, suggesting comparable long-term durability and safety when patients are selected appropriately for each procedure.
So patient selection is really key for CS.
Absolutely. Case selection for CCAS involves looking at specific clinical and anatomic features. SCAS is generally considered less suitable or worse for patients with advanced age, perhaps 80 years, though CREST data tempered this, intolerance of dual antiplatelet agents, which are required after stenting, severe renal dysfunction due to contrast dye, or access-related issues like a very diseased or calcified shaggy or eggshell aorta, severely angulated aortic arch anatomy, type 3 arch, or significant aortoiliac occlusive disease making catheter passage difficult. Target vessel issues also matter: heavy calcification, severe tortuosity, twists and turns, a string sign near occlusion, presence of fresh thrombus, or unstable plaque morphology makes stenting riskier.
What about neck anatomy?
Yes, factors like previous neck irradiation or radical neck surgery, presence of a tracheostomy, severe neck immobility, or cervical spine fusion, recurrent stenosis after prior CEA, or very high lesions extending above the C2 vertebra, or very low lesions near the clavicle can make CEA technically challenging or risky, potentially favoring CAS. Similarly, contralateral carotid occlusion might favor CAS to avoid risking the only good side with open surgery clamping, although this is debated.
When is CA considered better?
CAS is often considered better or preferred for patients with significant medical comorbidities that increase the risk of general anesthesia or open surgery. This includes severe COPD, significant coronary heart disease like an abnormal stress test, unstable angina, or recent MI 1 month ago, severe valvular heart disease, congestive heart failure, especially EF 30%, contralateral recurrent laryngeal nerve dysfunction to avoid risk of bilateral vocal cord paralysis, or severe obesity. It's also the preferred approach for restenosis after a prior CEA.
How does CAS actually work? What's the process inside the artery?
Prior to CAS, high-resolution imaging like MRI or CTA of the aortic arch and carotids, and sometimes a cerebral angiogram, evaluate the individual anatomy precisely. Femoral artery access is obtained in the groin, similar to EVA. A sheath is threaded carefully through the aortic arch into the common carotid artery on the operative side. A guide wire and, crucially, an embolic protection device, EPD, are advanced through the sheath and positioned across the stenotic region in the internal carotid artery distal to the lesion. This filter-like device, or sometimes a balloon occlusion device, is designed to sequester any emboli, plaque debris, or clot dislodged during angioplasty and stenting, preventing them from traveling distally into the cerebral arteries. EPD use is standard and has significantly lowered the intraoperative and postoperative stroke rates associated with CAS.
The balloon is stent.
Right. Sometimes predilation with a small angioplasty balloon is performed first. Then the self-expanding carotid stent is deployed across the lesion. Often, post-dilation with a slightly larger balloon inside the deployed stent is done to ensure full expansion and apposition to the vessel wall. Finally, the guide wire and EPD are carefully removed after final angiography confirms good flow, no carotid artery dissection or occlusion, and no trapped debris in the filter. Fluoroscopy is used throughout, requiring lead shielding for personnel in the room. The most common anesthetic for CAS, as mentioned, is local anesthesia at the femoral insertion site, often combined with minimal conscious sedation for patient comfort. Standard antithrombotic therapy, aspirin and clopidogrel beforehand, heparin during, is used, along with observation for hypotension and bradycardia. Anticoagulation starts with a heparin bolus, 50 to 100 units to maintain an activated clotting time, ACT, 250 seconds. Balloon inflation in the internal carotid artery, particularly near the carotid sinus at the bifurcation, can stimulate the baroreceptor reflex, causing potentially prolonged bradycardia and hypertension. This can often be offset by administering glycopyrrolate or atropine proactively before balloon inflation.
Are there unique complications with stenting compared to open surgery?
Yes. While less invasive overall, CAS has its own set of potential complications. Stroke remains the most common serious complication, usually due to thromboembolism during or shortly after the procedure, despite EPD use. Myocardial ischemia or infarction can occur, though generally less frequently than with CEA. Bradycardia and hypotension related to baroreceptor stimulation are common interprocedurally. Technical issues can include deformation or incomplete expansion of the stent, acute stent thrombosis, clotting, carotid artery dissection or rupture, rare but serious, and hemorrhage from anticoagulation, e.g. groin hematoma. Horner syndrome, droopy eyelid, small pupil, can occur from sympathetic nerve irritation. And cerebral hyperperfusion syndrome can also occur after CAS, similar to CEA.
What happens if a stroke occurs after CAS?
For acute stroke post-CAS, immediate airway and hemodynamic management are critical, along with an immediate CT scan and potentially angiography to identify the cause, c.g. embolus, stent thrombosis, dissection. Neurologic deficits are significantly reversible if CBF is restored rapidly, ideally within 2 hours. Treatment can include catheter-directed thrombolysis, like recombinant tissue plasminogen activator RTPA, or catheter-based mechanical thrombectomy to retrieve the clot.
So comparing outcomes overall.
Yeah. In general, as the trials suggest, CVA incidence tends to be slightly greater with CAS pure procedurally, while MI incidence is generally greater with CEA. Long-term morbidity and mortality comparisons are presently considered largely inconclusive or showing equivalence based on CREST 10-year data. However, due to the consistently observed slightly higher risk of periprocedural stroke with CAS, particularly in earlier trials, CEA is currently still often considered the preferred method for managing asymptomatic carotid stenosis in standard risk patients by many guidelines, though CEA is a valid alternative, especially if anatomical or medical factors favor it. The choice requires careful discussion between the patient and the vascular team. Post-CA, patients typically stay in PACU for observation, maybe 30 minutes, and then are transferred to a monitored floor overnight. A carotid duplex scan is performed before discharge and then routinely at intervals like 6 weeks, 6 months, 1 year, and annually thereafter to monitor for instant restenosis or other issues. Patients remain on dual antiplatelet therapy, aspirin and clopidogrel, for a period 1 through 3 months, and then usually on aspirin or sometimes clopidogrel alone, lifelong.
Wow, we've really journeyed through the entire vascular system today, haven't we? From the peripheral arteries in the legs all the way up to the critical vessels feeding the brain. What a deep dive indeed.
It truly highlights the incredible complexity and the ongoing evolution in understanding and treating these conditions. Knowing the subtle differences in risk factors, the intricate physiological responses during surgery like cross-clamping, and the nuances between open versus endovascular approaches really helps you grasp the full picture. It underscores that mastering this field like an elite professional isn't just about memorizing facts, but about understanding the interconnected systems and engaging in that critical thinking process.
Absolutely. From the inflammatory origins of atherosclerosis that started all, to the delicate balance of blood flow required during an aneurysm repair or a carotid stenting, it's clearly a field demanding constant learning and adaptation. We've seen how precise the interventions need to be, how critical the monitoring is, and how much careful thought goes into balancing risks and benefits for each individual patient.
And that's knowledge that empowers you, the learner, to truly be well-informed and to really appreciate the depth of this medical landscape.
So what stands out to you from today's deep dive? Maybe it's the sheer magnitude of the impact of something like smoking across so many different vascular conditions, or perhaps the really cutting-edge ways specialists are navigating the challenges of maintaining cerebral blood flow during carotid procedures. Keep those questions turning, keep thinking critically, and join us next time on The Deep Dive as we continue to unlock complex topics.